I'm Amitava Banerjee. I'm Associate Professor in Clinical Data Science at University College London, and I'm also an honorary consultant cardiologist at University College Hospital and Barts Trust in London. I took part in a debate this morning, man versus machine. Will AI replace doctors in healthcare? And I was presenting the argument from the side of humans. I don't want the machines to take my job, obviously, but really there's a lot of energy, research, sometimes hype in the space that, whether it's because of the large amounts of data or the increased computing power and the design of algorithms, that artificial intelligence is going to change the way that we do clinical decision making and ultimately deliver care. So I approached this from the angle of learning health systems, which is a data science and health informatics way of looking at the big picture system, where science, evidence and care all have large amounts of healthcare data, particularly with more and more electronic health records in the mainstream now, and they're being linked up in ways that before they couldn't be. There were previously, you had research in one silo and clinical care in another. So in the learning health system, you really need to have evidence for science, evidence for evidence, and evidence for care for AI to be better than the human. And my proposal is that it's not at the moment. So under the science heading at the moment, there are at least a couple of meta-analyses in the last year. So that means they've reviewed all of the available studies that have been published and looked at studies which have compared the best kind of AI, which is what's known as deep learning. That's where neural networks are trying to take heed of complex decisions with complex algorithms. And so far the data suggest that at best they're no worse than humans. There's definitely not evidence from the whole literature that the computer is doing better than clinicians, and that's on particular decisions relating mostly to imaging, where there's lots of data. That's not relating to the whole continuum of patient care. So at the moment the science is not up to speed. In terms of evidence, people are looking for evidence that AI is better than humans, but actually my contention is that AI can't function without good data. You'll get a garbage in, garbage out situation. And at the moment, the data that our health systems are geared up to produce, the way that I as a clinician am recording data, are not complete enough or good enough to do the kind of high level AI that we're after. And so it's, what's done in a research study or in one piece of work is not implementable at system-wide level. Also, the data that you've got has problems such as, it doesn't represent people who are non-Caucasian. If you look at genetic data internationally, only 20% of data is in non-Caucasians. If you look at the people who are using digital healthcare, it tends to be younger, more well populations with less comorbidity. So if we use that to generalize, it's not going to represent everybody. So there are problems with the data as well. So no science, not enough evidence. And in terms of care, you need to have a situation where medical students and doctors are trained to use the new digital technology and know the opportunities and the pitfalls with AI, and also how to use it to make decisions. And the answer is at the moment we don't. Also, we need to make sure that decisions are still patient-centered rather than data-centered and technology-centered. There is a difference between these three, and a lot of people claim to be acting in a patient-centered way when actually, patients need to make that judgment, and ultimately whether or not a treatment or management pathway happens is a patient's prerogative, not an algorithm's prerogative. And then also we need more transparency in terms of conflicts of interest, in terms of algorithms available. So I think that where AI fits in is there's no question that the technology is better in certain instances to be as good as, perhaps in certain instances to be better than human judgment. But in the overall pathway, it's there to kind of augment or improve the way we do things, not to replace. So electronic health records till date have largely been designed as billing tools, not to deliver patient care, not to deliver data for sophisticated healthcare AI. If you imagine the way we've designed mobile phones or Google searches, they're designed in a user-centered way. We need to design the actual interface in a way where it's easy for doctor and patient and nurse to input that data completely and with high fidelity. And I think also we need to train us health professionals about the importance and also the way to do that quickly as part of our routine care. And then I think we need a real change in who owns data. I think right now we have this situation where actually in the UK, for example, hospitals or GP practices own the data. The patient doesn't own their own data. But in terms of health and wellness and wearables and so on, those are the patient's data, or they might be the company involved. So it seems to me that the person who should be leading the orchestra is the patient in the middle. And that's the only way to stop all these different interests, because the patient will hopefully know their interests best. I think that would push us forward a long way.